proceed for your duty if you have any case.
Yes, sir.
Okay, Kamachi?
Thank you, sir.
Thank you very much.
Next, I invite Dr. Kalpana. She will present on AKA in ICU.
Yes, sir.
So, over to Dr. Kalpana.
Good evening, sir. Myself, Dr. Kalpana, doing first year DNB in Miot, sir.
Very good. I first appreciate you for boldly switching on your video. Like your
Thank
senior students who have been bold enough to expose themselves and or show off themselves to present. That's a good attitude. Thank you very much.
Today, I'm going to present about acute kidney injury in ICU patients. Definition of acute kidney injury: it's abrupt decline in renal excretory function and homeostasis, which leads to accumulation of waste and nitrogenous products. Diagnostic criteria: increase in serum creatinine more than 0.3 milligram per deciliter within 48 hours. Increase in serum creatinine more than 1.5 times in 7 days, or urine output less than 0.5 ml per kilogram per hour for 6 hours. It is diagnosed based on 3 criteria. Initially, we'll diagnose it with rifle criteria, which stands for risk, injury, failure, loss, and end-stage renal disease, which is further classified based on GFR, glomerular filtration rate, and urine output. In risk category, the based on GFR, if the creatinine level is more than 1.5 times the baseline increased. In urine output, if it is less than 0.5 ml per kilogram per hour in 6 hours. In injury category, if the creatinine level is more than 2 times the baseline, or the GFR decrease in GFR more than 50%. In injury category, the urine output less than 0.5 ml per kilogram per hour for 12 hours. In failure, if we term as failure, if the creatinine level is more than 3 times the baseline, or the falling GFR more than 75%, or the creatinine level rises more than 4 milligram per 100 milliliter. In terms of failure, if the urine output is less than 0.3 ml per kilogram per hour for 24 hours, or anuria for 12 hours. Persistent acute renal failure for more than 4 weeks, it's termed as loss, and the end-stage renal disease, and further comes the end-stage renal disease. Another criteria we classify AKI is AKIN criteria, acute kidney injury network criteria, which is proposed in 2007. It has 3 stages, which is further based on serum creatinine as well as urine output. Stage 1, the serum creatinine level more than 0.3 milligram per deciliter, or the rise in creatinine level more than 1.5 to 2 times from the baseline, or urine output less than 0.5 milligram per kilogram per hour for 6 hours. Stage 2, serum creatinine level rise more than 2 to 3 times the baseline, or urine output less than 0.5 ml per kg per hour for 12 hours. Stage 3, the serum creatinine level rise more than 3 times the baseline, or the urine output is less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. Another criteria we used to classify acute kidney injury is KDIGO, which is kidney disease improving global outcome criteria, which has the same stages as of AKIN criteria. Types of AKI. Patients will have termed AKI based on pre-renal, renal, and post-renal. Pre-renal AKI involves there is disturbance in the hemodynamic status of the patient. Further classified based on fluid loss, which can be a renal loss due to diuretics, or polyuria, which can be gastrointestinal loss or hemorrhage, or else it can be a decreased cardiac output status such as heart failure, pulmonary embolism, acute myocardial infarction, or it can be systemic vasodilation like sepsis. Sepsis is the most common cause of acute kidney injury in patients in ICU. It may be due to afferent arteriolar vasoconstriction, which is due to drugs like NSAIDs and ephedrine or radiocontrast materials, and renal arterial disease, which involves renal arterial stenosis. Next, AKA due to intrinsic causes, which is intrarenal AKA, which involves acute tubular necrosis, glomerulonephritis, and acute interstitial nephritis. Post-renal AKA involves obstructive causes like calculi, any BPH, post.
Your audio is gone. Dr. Kalpana, with your
Sir?
audio, ma?
Hello, sir.
Yeah.
Can you hear me now?
Yes.
Post-renal AKA, it may be due to obstructive causes, due to calculi, and also prostatic diseases, pelvic malignancy, or uric acid nephropathy, tumor lysis syndrome, and all. Moving on to examination part, how we gonna diagnose AKI? Patient in ICU will go for examination part where the patient shows cardiovascular examinations. There will be irregular cardiac rhythm due to hyperkalemia, accumulation of potassium, cardiac murmurs, or features of heart failures like raised JVP, lung-based crepitations, presence of third heart sounds, severe hypertension, also suggestive of cardiac failure or fluid overload symptoms. Respiratory symptoms, we have Kussmaul's breathing, which indicates acidosis, fine crackles, which further denotes heart failure. Abdominal examinations will have in case of post-renal AKI due to obstructive causes, we'll see a full bladder, distended tense abdomen due to any obstructive symptoms. Neurological examination will note, we can see confusion in symptoms of uremia, hysteresis, which is a heparorenal failure, limb edema. Everything can be seen in the case of examination part. And investigations will we'll see biochemistry investigations will see for serum urea and serum creatinines, which is raised more than the normal baseline, and we'll look for pH to rule out the acidosis cause. And we'll see for electrolytes where the potassium is raised, which is dangerous. And we also look for creatinine kinase to rule out a rhabdomyolysis causing AKI. Urine analysis, hematuria, proteinuria,
Again, your audio is
drug-induced drug. Hello.
I think you have to keep your mic close to your mouth, ma.
Sorry, sir.
Yeah, continue.
Hello, sir. Can you? Am
Yeah,
I audible, sir?
Yeah, you are audible now. Continue, please.
Sorry. Rhabdomyolysis is one of the serious complications which causes acute kidney injury. Here the culprit is myoglobin, which damages the renal tubular epithelial cells. The diagnosis of rhabdomyolysis is based on creatinine kinase, which is and also based on myoglobinuria. The urine myoglobin levels more than 20 microgram per liter is evidence of significant myoglobinuria, and we can also see the urine turn brown in color. Another major cause of acute kidney injury in patients in ICU settings is sepsis, which is a leading cause in ICU populations, is due to inflammatory cytokines release, which damages the capillary endothelium of glomerulus as well as the epithelial lining of renal tubules. Renal tubular injury, which is also known as acute tubular necrosis, is characterized by sloughing of damaged cells into the lumen of renal tubules, which creates a luminal obstruction and which increases the pressure in proximal tubules. Which contributes to decrease in GFR, as GFR is based on the pressure of proximal tubule and the difference between arterial and venous pressures, venous capillary pressures. Major surgeries and multi-system trauma are also causes of acute kidney injury, with where the inflammation is also a major role. Multi-system trauma is the most common cause in also causes AK, in which multi-system trauma, rhabdomyolysis is the most common cause. Other causes are cardiorenal syndrome, where the heart failure decreases the perfusion, renal perfusion pressure, which in turn causes acute kidney injury. For investigations, we'll use for diagnosing acute kidney injuries, fractional excretion of sodium and fractional excretion of urea, urine osmolality, spot urine sodium, which these are used to differentiate between renal hypoperfusion and renal tubular injury. In renal hypoperfusion, the fractional excretion of sodium is less than 1%, but in renal tubular injury, it's more than 12%. Fractional excretion of sodium is the most accurate measure of renal tubular function, which is calculated by urine to plasma ratio for sodium divided by urine to plasma ratio for creatinine. If it's less than 1%, it's due to renal hypoperfusion. If it's more than 12%, it's due to renal tubular injury. And the urine osmolality status, and it is less than 400 milliosmoles per kg in renal tubular injury causes. Moving on to management, the first thing we have to do is treat the cause, which correction of the underlying cause, which is the earliest indication. In pre-renal AKAs, we will improve the renal perfusion, like giving fluid challenges and all. In intrarenal AKI, we remove the nephrotoxic agents and toxins which are damaging the kidneys. And in post-renal AKI, as it's due to obstructive causes, we try to remove the obstructive things. Maintenance, the first treatment we are going to give is fluid challenge. Fluid challenge we are giving to rule out renal hypoperfusion. Initially, 500 ml of crystalloids we have to administer and watch for urine output. If it's improving, we can continue with fluid challenge. And diuretics are less used in case of renal hypoperfusion. It only used if there is we can surely use diuretics if it is no renal hypoperfusion is there. And a low dose of dopamine can be used in 2 microgram per kg per minute, which causes renal vasodilation. Finally, renal replacement therapy can be done in cases wherein the severe refractory hyperkalemia, symptomatic uremia, metabolic acidosis, toxins which can volume overload, severe volume overload, toxins which are only can be removed by renal replacement therapy. And management of life-threatening complications includes, in case of severe metabolic acidosis, we should maintain the optimal pH by giving intravenous sodium bicarbonate. And hyperkalemia can be managed by giving IV calcium gluconate to stabilize the membrane, which is 10 ml of 10% calcium gluconate over 10 minutes. And we can also give intravenous insulin in 50% glucose over 10 minutes. And we'll give nebulization through salbutamol. And underlying uremic pericarditis, cardiac tamponade can be managed with oxygen peripheral vasodilators and pericardiocentesis.
Okay. Good. It was a good presentation on AKA. So without wasting time, I'll just go to show my PPT on that.